Appendix tumors and Pseudomyxoma peritonei, the complete guide the patient needs. Appendix cancers are rare, but their impact is significant. Many people are diagnosed accidentally after an appendix removal or a scan performed for another reason. Some discover them only when the abdomen starts increasing in size gradually with no pain at all. The challenge is that appendix tumors behave differently from almost every other tumor in the body. Hello, I am Dr. Anuj Suketu, GI Gynec Peritonal Surface Oncosurgeon. I want to give you a complete, clear explanation of appendix tumors, Pseudomyxoma peritonei, and how mucin spreads and why early treatment decision shapes the long-term survival. Let us start with the basics. The appendix is a small organ, but certain tumors that arise here can produce mucin. This mucin behaves like thick jelly. It can leak or spread inside the abdomen, coating organs slowly. People often feel a sense of bloating or heaviness long before they feel the pain. Some women mistake these symptoms for ovarian issues. Some men ignore it because it feels like gas or acidity. When mucin spreads, we call the condition Pseudomyxoma peritonei or PMP. It is rare, and because it is rare, many doctors may not recognize it early. This leads to a delayed referral and sometimes suboptimal first surgery. The critical point is this appendix tumors and PMP needs specialists trained to treat peritoneal disease. The wrong initial surgery can make future surgery far more difficult. Now let us talk about diagnosis. Ultrasound may show fluid, but it cannot distinguish between mucin from normal fluid. CT scan gives better clarity. They show pockets of dense material, scalloping of the liver surface, and displacement of the organs. But even then, the report interpretation needs experience. Sometimes a diagnostic laparoscopy is needed to understand disease distribution and confirm the pathology. When PMP is confirmed, the gold standard of treatment is cytoreductive surgery, CRS, followed by HIPEC. CRS removes all visible mucin and tumor deposits. Depending on where the mucin has spread, this may include removing the omentum, parts of the peritoneum, small tumor nodules on organ surfaces, and sometimes the spleen, or a limited resection of the bowel. The goal is complete clearance. HIPEC follows, targeting microscopic disease with heated chemotherapy. This combination gives the best long-term control. Without CRS HIPEC, PMP always returns and continues spreading. People often ask, is PMP curable? The answer is encouraging. In many patients, especially those diagnosed early, treatment can lead to long-term remission. Some remain disease-free for many years. Outcomes depend heavily on tumor grade, biological behavior, and completeness of cytoreduction. Recovery after CRS HIPEC for PMP follows a structured pattern. Patients regain strength gradually, build mobility through physiotherapy, and receive focused nutritional support. The abdomen takes time to settle, but most patients resume normal routine in a progressive manner. What matters most in follow-up? Regular imaging and blood tests help detect many recurrences early. When it is still operable, to summarize, appendix tumors and PMP are rare, but they are treatable. When handled by a trained team, outcomes can be excellent. The key is early referral, correct staging, and choosing a center experienced in peritoneal oncology. This disease is slow, but the decision around it must be timely.